It's my pleasure this morning to welcome everybody to the annual Raisbeck Visiting Professorship. And I just want to make a shout out to the Raisbecks. James and Sherry Raisbeck provided the division with a large grant that we use both for education and also seed grants to our fellows and our junior faculty members. And James died about 3 years ago, but Sherry continues to be very generous to the university as a whole. And they continue to fund both chairs and also grants in multiple divisions and departments. So it's really my pleasure this morning to welcome Lynne Stevenson as our Raisbeck visiting professor, and we spent yesterday with her. She met a lot of the fellows and a lot of the faculty, which was terrific. Many of you know Lynne. Lynne went to Princeton. She graduated summa cum laude in biochemistry, and then she went to Stanford Medical School, and then did her internship at Stanford, and then her residency at UCLA, and her cardiology fellowship at UCLA. And with that history of underachievement, Lynne has continued to make major contributions in the area of heart failure. Lynne was at UCLA, where she led their heart failure efforts, and then she went to the Brigham, where she again led their heart failure efforts, and now she's at Vanderbilt as the director of cardiomyopathy. Lynne has been involved with really every major clinical trial of heart failure that I can remember. I mean, she's really been at the forefront of figuring out how to take care of our patients with heart failure. And as I told the fellows yesterday, I think of all the people who I know in heart failure, Lynne has really changed my approach to heart failure, my understanding of the pathophysiology and how to approach heart failure. And I think that's true for a lot of us in heart failure. She's made major contributions. We all know about warm and wet and cold and wet. And actually, that was Lynne's incredibly insightful way of assessing heart failure. And we all use it every day in our clinical practice. This morning, I just want to introduce her, and we're thrilled that she's here. And she's going to talk about guidelines in heart failure. Lynne, thank you.
Good morning. Well, it's such a pleasure to be here. I've really enjoyed my trip and very much appreciate James Resnick for helping us to get together here. It's really been a wonderful visit, and I look forward to talking to you. I'm not advancing. Left and right. All right, thank you. So I do want to say I have no financial relationships at all, and it will be pretty clear that I'm relatively unsympathetic to a fair number of the our industrial partners. I've been in the guidelines committee for over 20 years, and so I've seen a lot of versions. And one of the things you realize is that there's rarely consensus among the committee. So every time you see something, it in fact is the result of a lot of collegial, but sometimes relatively serious discussions. So what we're going to talk about, reading between the heart failure guidelines, we'll talk about heart failure staging. It matters what we call it. The pillars of heart failure, how we apply guidelines to people in the hospital. Moving beyond GDMT, give you a little bit of preview of a new definition of stage C2D. We'll talk about transitions and heart failure mid-range ejection fraction, which frankly, I'm not happy with that terminology. Talk a little about heart failure with preserved EF. Let me just emphasize, I'm going to focus much more on heart failure with reduced than preserved ejection fraction. And devices are for another day, although there are many interesting things going on with the devices. So it matters what you call it, because that's how you decide how you're going to treat it. Let me review the staging of heart failure where we are currently. Basically, we start with stage B. Those are people who already have structural or biochemical abnormalities, but don't yet have any symptoms and have not had symptoms. Stage C is symptomatic heart failure, but it's becoming a little bit more granular, where we have heart failure with improved ejection fraction, we have persistent heart failure, and then I'll talk a little about stage C2D, which is sort of beyond the usual stage C. And of course, stage D is A lot of what you see here in an amazing transplant program that you have here. You're very familiar with that. So it matters what causes it. Heart failure is a syndrome, not the disease. That's one of the things I'm most known for in the selection committee meeting, to say, yeah, I understand he's really sick, but what's the disease? And the recommendation is for patients presenting with heart failure, the specific cause should be explored using additional laboratory testing and for appropriate management. The 2022 guidelines, the first time that genetic testing is mentioned in the guidelines. Back in 2013, there was a recommendation that you take a good family history. That certainly continues in the 2022 guidelines, but now it's the first time as a 2A in select patients with non-ischemic cardiomyopathy, referral for genetic counseling and testing is reasonable. And just want to emphasize, however, that absence of a family history does not mean that you don't have a genetic disease. And similarly, you may have a strong family history, and yet we may not be able to find the gene, the so-called gene-elusive cardiomyopathy. I'm not going to talk about devices except for one thing, which I think it's important to realize, which is that we have actually the least restrictive indication for primary prevention ICD in the 2022 guidelines, which is that in patients with genetic arrhythmogenic cardiomyopathy with high-risk features with an EF of less than 45, implantation of ICD is reasonable to decrease sudden death. And I would point out, it doesn't say you have to know what the gene is. So if you have someone with a very strong family history, you can get them in under this indication. And as a preview, I think we'll be moving to a time when an EF of less than 35 is neither necessary nor sufficient indication for primary prevention ICD. So let's move on to the pillars. The three traditional pillars of medical therapy for heart failure reduced ejection fraction through 2013, the ACE or ARBs, beta blockers, and mineralocorticoid antagonists, these have been incredibly effective. People talk about them as sort of the old pillars, but really, this is the group of medications that really changed heart failure. Marked decrease in sudden death even before ICDs. We saw many people living for a long time despite low ejection fraction. So this is a very powerful trio of therapies. And this just reminds us of this. This is a Danish nationwide study where they looked at all the people in their country, and they looked at people who had been hospitalized with heart failure, a new diagnosis, who were under 70 years and did not have any major comorbidity. And then they looked at those who were on ACE inhibitors and beta blockers by 4 months, and then looked at what happened to them. Quite remarkable. 5-year mortality was only 14% in this group. And of the survivors, 78% had neither a hospitalization nor an increase in their diuretics during the 5 years. And so this is just ACE inhibitors. It's amazingly powerful therapies. So we can't forget that when we look at the newer ones. So sacubitril valsartan is not just a new improved ARB. It inhibits neprilysin, which degrades many peptides. Everybody thinks about the natriuretic peptides as being the major effect of neprilysin. In fact, it turns out that ANP is far more dominant than BNP. We just don't measure it because it's such a short half-life. Interesting question as well is how important bradykinin will be, because neprilysin breaks down bradykinin, which has been implicated in some of the benefits of ACE inhibitors. One of the things we find is that patients often feel remarkably better, even if they weren't very bad before. It turns out that neprilysin also breaks down endorphins and enkephalins. And at least in animal models, this may be important, although it doesn't seem to be that important, at least when it's been assayed in humans. Let me just remind you, it is combined with valsartan. Combined with valsartan because neprilysin breaks down angiotensin. So if you don't inhibit the angiotensin receptor, then you'll actually end up with an increase in angiotensin, which is obviously not what we want. So paradigm heart failure, very well-known trial because it really changed the paradigm. Let me just review briefly how this trial was done, because it's rather unusual. In order to get into the trial at all, you had to tolerate an equivalent of enalapril or lisinopril or ARB before you even got in the trial. Then you had to tolerate 10 milligrams twice a day of enalapril. Then you had to tolerate 200 milligrams BID of sacubitril valsartan to get into the trial. So we are selecting patients who can tolerate a robust dose to even get into the trial. Then once they get, and this is a pretty healthy, 70% class 1, I think it was probably about half of the patients had never been hospitalized. But this is a very healthy population. And in that population, on top of everything else that they were on, there was a significant benefit in all the components of the endpoints. However, let me remind you that all these other trials that have gone on, we ended up with a pretty low mortality group, even before they got into the trial. What this shows is the annualized mortality taken from the data in a lot of trials, extrapolated back to get to 1 year. And at the far end is the Paradigm trial. And you can see that the mortality is less than 10%. And with Entresto, it's a little more or less than 10%. But we're not looking at a group of patients who are necessarily headed for early death. So when we look at this picture up on the top, this was the original advertisement that was on TV for Entresto, and it was quite frightening. If any of you saw it, this man's reading his book, and the water's coming up, and the dog's looking with terror at this man. It was actually taken off because we all complained this is way too scary when you look at this mortality down there. So then they moved to the next one, which is the guy that put both the man and the dog in a boat. And then the last one, which is really the most mild, is that, if you want to go out, and have a nice date with your spouse on the riverside, then Entresto will help you do that more. So this is when I talk about reading between the guidelines. It's very interesting to look at. In 2017, which is after it was released, basically this was the guideline. It was a level 1 with very good data, and it was basically included with ACE, ARBs, ARNI, all included together. And it said that the clinical strategy of renin-angiotensin system inhibition with any of these basically is recommended to reduce morbidity and mortality. Now here's the 2022 guideline. It's a little different. The top says, in the patients with HFrEF and class 2 to 3 symptoms, the use of ARNI is recommended. So now it's just saying class 2 to 3. So what happened between 2017 and 2022? Well, one of the things, if you go back and look at this trial, despite having to tolerate these incredibly large doses of the renin-angiotensin system antagonist, they went back and looked at pretty high incidence of hypotension, even if you tolerated all that. And this is a study looking at it in relation to the systolic blood pressure at the time of randomization. And if your blood pressure was, 110 or less, you had a quarter chance of having a hypotensive episode. So in fact, a little bit of concern about people whose blood pressure isn't that robust. And so what was happening is that it was being recommended for everybody in the hospital, out of the hospital, and the LIFE trial was done. This is the only sacubitril valsartan trial that is not industry-sponsored. This is NHLBI-sponsored trial with the Heart Failure Network to specifically look at people at the far end of the spectrum, to try to define the boundaries here. And so they took patients who had been on GDMT and had one of multiple risk factors, including recent heart failure hospitalization, low peak VO2. There was and in the hospital now, there was a run-in with sacubitril valsartan, and 17% dropped off the run-in, which is the lowest dose. An additional 17% who were randomized also had hypotension compared to 12% with valsartan. And here's the result. If you look at the incidence of CV death or heart failure hospitalization, sacubitril valsartan is not winning. It's not anywhere close to winning, no matter how long the trial had gone on. And the trial results were released during the finalization of the 2022 guidelines, which is why class 4 was taken out of the recommendation for sacubitril valsartan. So if we look at the complete wording, basically now it has class 2 to 3 for ARNI, but for ACE and ARB, 2 to 4 remains in there. And here's the summary figure, lists the ARNI first for class 2 and 3, but ACE and ARB for class 4, because some patients are, like the trial, they're lifelike. So now we're moving to 4 pillars. Is it 4 pillars? Because it's 3 pills. So it's a little confusing exactly how many pillars we have. But let's move on to the next pillar now, which is the SGLT2 inhibitors. Their main obvious effects, they increase glucose excretion in the urine, which is why they were originally used for diabetes. They have multiple other effects. This is just a combination of things. There's less uptitration of diuretics, shown on the left in people on SGLT2 inhibitors. If you look at empagliflozin, there's data showing that it decreases the pulmonary artery pressure over a month. This was from data with the implantable hemodynamic monitor. And if you look at clinical outcomes with kidney disease too, this is something that we think probably affects the longer term benefit of these agents, because kidney function, of course, is one of the things that leads to worsening of heart failure outcomes. Specifically helpful just for people with kidney disease, even without heart failure. So how do we compare these two? Well, John McMurray actually was involved in both trials, and he calls it trying to decide between your children. If you look overall at the hazard ratios, they're very similar. For CV death and heart failure hospitalization, 0.8 for Paradigm, 0.75 for the dapagliflozin. But notice, again, the populations are very different. So for Paradigm, you had to have robust blood pressure and tolerate that big run-in. There's no run-in period needed for SGLT2 antagonists. You had to have a blood pressure over 95. Basically, there are more people in, we've tested it in more people with more advanced heart failure. So in fact, it's pretty easy to start, and most patients tolerate it. But if you look at the hazard ratios, they look pretty similar. Now, hazard ratios are relative, but patients are absolute. So how many patients do you need to treat to prevent an event? Sorry, just remind you here that if we look, so this basically is a level 1 for that. But looking at the number needed to treat now, for both of them to decrease one event of either death or heart failure hospitalization, if we look at sacubitril valsartan, you have to treat 21 patients for 27 months to decrease one event. So when a patient is not able to tolerate it, I try to convince them, in fact, that they're not dooming themselves to death without sacubitril valsartan. It's really important that we keep this in perspective. And for CV death and heart failure hospitalization, it's very similar for dapagliflozin. For all-cause death, it's a higher number needed to treat, and that's higher with dapagliflozin. So now we have our 4 pillars. So just to review these pillars, the classic ones have been highly effective. Entresto has further improved outcomes in class 2-3. SGLT inhibitors are recommended for a broad range of patients, class 1 to 4, patients with diabetes with or without heart failure, patients with or without kidney disease, and as we'll talk about later, it's across all EF. Let me just tell you, I'm not saying the SGLT1 or 2 inhibitor, because we do have sotagliflozin, which inhibits both 1 and 2, which has also been demonstrated. But it is not life or death with these new ones. I really want to get that across. The number needed to treat it is greater than 20 patients to prevent a heart failure event and 35 to 50 to prevent a death. Well, where are diuretics in these guidelines? We use a lot of those. These 4 pillars, in fact, are going to just float away if we don't try to do something about congestion in people who have congestion. We look back at 2013, it's kind of startling. The only recommendations for diuretics were to improve symptoms. And it said there's no evidence for any other benefit. It was often said diuretics treat symptoms, but there's no basis of evidence that they improve outcomes. And then observational studies showed the use of diuretics in heart failure is associated with worse outcomes, and higher doses are associated with the worst outcomes. Well, of course, this is the problem of confounding by indication, because the need for the therapy is what indicates the worst disease, not the therapy. And you also have to be aware, by the way, of the converse in observational studies confounding by contraindications. The apparent benefit of taking a therapy, or higher doses of therapy, may also reflect that you've just selected a patient who can tolerate it, not that the therapy is as good as you would think. Okay, so here's, this just shows you in this little diagram from 2013 that it said that for, basically for stage C, class 1 to 4, first you do the ACE and ARBs and a beta blocker, and if there's volume overload, then you add a diuretic. Well, this isn't the way we do it at all. Now, one of the things, and this is a concept in terms of particularly for fellows who hopefully are watching us on Zoom, there's an inverse relationship between the weight of the impact of your therapy and how much evidence we can get from a randomized controlled trials. And the British Medical Journal had a classic on about parachutes. We've got no data on parachutes. That's because the impact is so great. Who's going to test that? And I would say that in somebody who's really short of breath, who's going to test whether Lasix works or not? And what patient wants the placebo? So if we look at chlorothalidone for hypertension, we've got hundreds and hundreds and hundreds of thousands of patients in those trials because they feel fine when they start it, whether they take it or not. But we don't have much for furosemide to prevent and relieve congestion because it's a little closer to the parachute in terms of how important it is immediately. So just bear in mind, just because we don't have a trial doesn't mean that it's not very impactful. And in the Pioneer study, which looked at sacubitril valsartan versus enalapril at discharge, despite this new therapy, et cetera, over 50% of patients needed a 50% increase in outpatient diuretic dose within 4 to 8 weeks. So we really do need diuretics in many of these patients. And here's some late breaking news, in fact. This won't really surprise any of you. But an observational trial of about 8,000 patients in the optimized registry, they took people who were admitted with heart failure without diuretics, and then they looked to see who went home on diuretics. But the stunning thing was they were able to identify 2,000 of those patients who in fact went home without diuretics. That to me was the startling part. And a real surprise to you, in fact, they did worse. And that even doesn't account for the fact that most of them got started on diuretics soon after they went home. So this, although it doesn't surprise anyone, was considered to be really nice level B evidence. So with this, we can now say that they do improve morbidity. And now for 2022, they're in there not only to relieve congestion and improve symptoms, but to prevent worsening heart failure. And it's now also in the algorithm there. I'm just disappointed that the algorithm was actually done in gray like that, so you can hardly read the thing that says address congestion. But it does have that before you move on to the other therapies. So we've made some progress for diuretics. So getting to dry before discharge, now if we look at it, it says for patients requiring diuretic treatment during hospitalization, the discharge regimen should include a plan for adjustment of diuretics. But here's this small thing, is that the committee would not let us say should include diuretics, because we said, well, lots of people may turn out not to need them, but it was okay to include a plan for diuretics. So these subtleties in the guidelines often hide a lot of discussion. So just to review, and we talked about this in a smaller meeting yesterday, we now are allowed to say that our major goal in someone hospital is to relieve congestion. And then once that's well on target, we move into optimization of guideline-directed medical therapy. So if we look at the guidelines, it says that basically titration of guideline-directed medication should be started and escalated as soon as possible. And for patients in hospitals shown in the bottom, GDMT should be initiated during hospitalization after clinical stability is achieved, and it's hard to argue about that. However, it does come out to look at these two different strategies. One, you can just start everything all at once, or you can hit your target and sort of wait till you've made some progress before you add everything together. So SGLT inhibitors have actually specifically been tried in hospitalized patients. If we look at sotagliflozin, for instance, death and heart failure events were decreased when you started it. If we look at the Impulse trial, Dictate trial, and I didn't update this, but the Dictate trial that Dr. Lindenfeld led with empagliflozin, basically, dapagliflozin, showed that you had an increased amount of diuresis. So now in the current pathway, this is not the guidelines, this is the ACC pathway for patients hospitalized. SGLT inhibitors are now fine at any time during hospitalization. MRAs can also often be started if the potassium and renal function allow. There's a little more likelihood of decreasing the blood pressure for 2 to 3 millimeters with MRAs, but it's pretty reasonable to start them as long as renal function's okay. Larry Allen came up with a really nice concept of spending function, which comes from investment framework for when you have to decide what you're going to spend something on. In the hospital, the main spending functions are blood pressure, renal function, and cost. So just trying to keep those in mind. And one of the things in the revised version that just came out of the ACC pathway is think about how your patient came in when you try to decide what you're going to do with the neurohormonal antagonists in the hospital. And this is roughly proportional to the patients in the major trials in terms of the patients with a new heart failure diagnosis. They're already going to be in the SGLT2 inhibitor. Now you need to personalize your initiation of the pillars of GDMT, paying attention to the blood pressure and kidney function, et cetera. But most people in the hospital are in this middle circle. They have chronic heart failure on partial GDMT, and you need to decide the degree to which you can up-titrate doses or fill in the gaps there. But because of the LIFE trial, we now recognize that there is a group with chronic class 4 heart failure despite attempted GDMT, in which caution is required to initiate or up-titrate the renin-angiotensin inhibitors or beta blockers. And in those patients, we may need to reevaluate. It may be someone who should be considered for transplant or VAD. You need to think about what's the long-term trajectory for those. So when we look at it, we really need to individualize care. This is one of my favorite slides. It's the winner of the Not My Job award when we're thinking about painting lines. And the same thing with guidelines. Just following the guidelines is no excuse for doing something that's not the right thing for the patient. So just to summarize the pillars of medical therapy, now the classic ones are very powerful, ARNI and SGLT2 inhibitors. But the benefit of new therapies can be overstated from looking at the relative ratios of benefit. Once congestion has occurred, the diuretics are foundational to keep the pillars from flooding. And patients who have been hospitalized require special consideration. So now I want to give you a very short preview of what is now being called stage C2D heart failure, C2 being sort of the sicker end of stage C, moving towards stage D. So basically it falls into this gap between C2 and D, what we call sort of the C2D, and to a great extent, they are beyond GDMT in terms of deriving further benefit from that. So this is a growing population. It's estimated 250 to 300,000 patients in this group with ambulatory advanced heart failure. One of the interesting subgroups is the palliative inotropes, about 4,000 to 6,000 patients per year. We know nothing about those patients, and yet there is many patients going for that as are going for transplant. And Shannon Dunlay has done a wonderful job of putting together a lot of this schema. We don't know much about what to do with these patients. If you look back at all our major trials of the heart failure medications, if you look at the dark bar, those are the patients who have class 4. The not quite so dark is class 3. So we really have very little information about what to do in that C2D group. So when do the pillars no longer support advancing heart failure is something that we need to be looking into. Well, digoxin, I was talking about this with Dr. Fishbein, is better than we recommended. If you go back and look at this, you're going to be stunned if you compare it to things we currently look at. So top left, that is the benefit for death or heart failure hospitalization across the whole DIDS trial. You look at this now, you say, that's a blockbuster drug. All-cause death was completely even. Death from heart failure is less. And this is the whole population. If you look now at the class 3, and there are very few class 4 in this, it's an astonishing impact as you look up here. And if you look at the EF less than 25, you see the same thing. So there is clear benefit of digoxin in this group of patients. So we may be wanting to think about it in the stage 2D. It was just snubbed in the guidelines, frankly. I think to put it down at a 2B is really rather rude for what's a very powerful, even if quite old, drug. And then it, of course, gets a recommendation also for atrial fibrillation. I'm not going to go into it. It's not approved yet. Omecamtiv is the myosin activator. And if you look at the subgroup from that trial who had severe heart failure, class 3-4, hospitalizations in 6 months, this is the classic C2D patient. And there's a remarkable benefit shown there. And I'm happy that they have resurrected this drug and putting it back into trials. So just to recognize this population, and it's a call to action. Who are these patients exactly? Well, some of them could be the people who went in the LIFE trial. Patients who are rehospitalized with heart failure despite adherence and GDMT, patients in whom you're diminishing your GDMT while you increase your diuretics, and certainly Dr. Levy's Seattle heart failure score would be a very nice way, I think, to begin classifying some of the patients in this C2D population. So let me move on now to transitions and the dreaded heart failure mid-range ejection fraction. So basically, before we get there, let me just have a moment to tell you about heart failure improved ejection fraction, which is a major component of the mid-range ejection fraction. This is not a country, it's not a diagnosis, it's a crossing in most cases. First, you exclude some obvious things, amyloidosis, valve disease, other restrictive disease, people who have just had one MI. The patients remaining are mostly heart failure with reduced ejection fraction in transit up, or some are heading down to a lower EF. This, for those of you who are old enough to know, this is from the movie Casablanca, and Rick is examining the letters of transit to get people out of Casablanca. In fact, there's a lot of transit from this mid-range ejection fraction. Several studies show that over the next 2 years, that 45% increase, 22% decrease, and about 33% stay in the mid-range. So note that a lot of these people actually have the improved EF. This was first reported by Lynne at the Brigham. And basically, it was called recovered at that time. Wrong term. So it didn't name it very well, but it's in fact a third of our clinics. And we had no idea. We were actually doing a study to compare HFpEF and HFrEF. And Lynne came and said, well, what am I going to do with all these people in the middle? And it was stunning. And then basically, I think it doesn't matter what you call it. And I think that the group from Basseret, which is a multi-center group, looking at this really helped us a lot, because they pointed out that if you look at the patients who have the so-called recovered EF, which is down here in the green line, it's still not normal, because over the next 8 years, there was about a 20% chance of having an outcome. And also that their biomarkers remain abnormal in many of them. So here's a really complicated slide. I don't want you to look at it in detail. I just want you to realize it's really complicated. This is the mid-range ejection fraction between 40 and 50, and it's full of all sorts of stuff. Most of them are the improved EF, as on the top. Start low and go high. Realize these people don't go to HFpEF. Sometimes people think that you move back and forth between HFpEF. I don't think so. As I'll discuss, I feel pretty strongly we shouldn't think about that as a continuum of one disease. Bunch of other kinds of diseases, sarcoid myocarditis, toxins, post-MI, that can go in and out through the mid-range. And then there's a group of restrictive who basically sit often in this range: amyloid, radiation, adriamycin, very different diseases. And HFpEF is rarely a specific cause of those. Some people with restrictive disease will present with HFpEF. Hypertrophic cardiomyopathy can sometimes so-called burn out and go to a mid-range. We think rather than using burnout, we're now trying to change the terminology to HCM with a reduced ejection fraction. So, well, here's the recommendations for heart failure mid-range ejection fraction. You're going to treat it just like HFrEF, with the diuretics, the SGLT2 inhibitors, and ACE and ARBs and MART. But you're just going to give them a lower level of evidence. I think this is really dangerous, to think about this as one group of patients with one set of diseases. For instance, if you have heart failure with improved EF, yep, we're supposed to continue it. If EF is falling from normal, it's probably reasonable to start it. But what about aortic stenosis or mitral stenosis? Well, that's not very good therapy for them. Restrictive diseases, beta blockers and renin-angiotensin antagonists are often not tolerated. Amyloidosis is dangerous if you use them. So it's really important to treat the disease, not treat the fact that they happen to have an EF between 40 and 50. Now we're going to move on to HFpEF, which I'm not going to talk about very much, but I do want to try to connect some of these things. First of all, it is defined by congestion, okay? That's the definition: evidence of spontaneous provocable increased LV filling pressures or natriuretic peptides that would reflect them. So they share congestion and the cardiorenal interaction. That's all the same. But is the therapy the same? Will neurohormonal pillars actually keep HFpEF out of the water? There's much less activation, and I don't have time to show you the data for that, of those neurohormones in HFpEF. So when it has been suggested, as it has been from a significant group of people, that that heart failure is just one disease with EF moving across, I think this is patently wrong. It's going to mislead us. We're calling it the wrong thing, and we're not going to treat it right. Because heart failure with preserved ejection is very different. First of all, beta blockers, interesting study, have been shown to increase hospitalizations and decrease exercise capacity. So that doesn't seem to work very well. If we look at the pillars, they're actually reversed between HFrEF and HFpEF in terms of everything is a 2B that is a level 1 for HFrEF. Sacubitril valsartan has not had benefit. If your EF is over 57, no benefit. And interestingly, it's more beneficial in women than in men, but it's clearly not the same as it is for HFrEF. Mineralocorticoid antagonists, still a much larger impact on HFrEF than HFpEF, as shown here on the left for 2 HFrEF trials, on the right for HFpEF with spironolactone, and most recently, finerenone looks exactly like spironolactone when you look at the impact on events. So although it's statistically significant, it's clearly much less dramatic than it is for HFrEF. So people are asking if SGLT2 inhibitors, after the data from DELIVER, are now ready for level 1. I think let's go back now and look at the issue of the number needed to treat. This is now looking at DELIVER, which is dapagliflozin in HFpEF versus HFrEF. If you look at the number needed to treat, for instance, to prevent a death, it's 111, so it's really not considered to have any impact. It's 31 for death and hospitalization, so clearly significantly less impact than it is on the HFrEF. Let's talk a bit about obesity. We're in a red state in more than one way. If you look at obesity here, compared to, you have the enviable position of being a yellow state with a little less obesity. This is a study from ERIC looking at 10,000 patients. And if you look in the pink bars, HF is markedly increased by obesity, HFrEF only a little bit, as shown here in blue. So obesity is a major contributor to this disease. And this is an old study, 30 years old, very interesting though, giving a saline load to people with obesity and no cardiovascular disease or diabetes, and they can't get rid of it. They're unable to increase their natriuretic peptides compared to normal people. And in fact, that's probably a major component of HFpEF. This is GLP-1 therapy. This is with semaglutide, a big winner at this point with semaglutide in patients with diabetes and patients without diabetes who have HFpEF. And so this is really an important thing now, I think, that perhaps will end up overshadowing the SGLT2 inhibitors. But here's an interesting thing in a subset analysis looking at people who were on SGLT inhibitors, showing that they basically did not show the same benefit from adding semaglutide. So we need a lot more information about how those two go together. This is, I think, a really interesting analysis that was done showing the effective therapies for HFrEF from semaglutide, SGLT2 inhibitors, that basically they are very significantly affecting diuretic use. And the therapies that improve outcomes also decrease the need for diuretics, which is not a surprise. There's no evidence of that for Entresto and some for spironolactone. Here's the latest news that tirzepatide trial, now adding the GIP peptide to the GLP-1 receptor antagonist. EF over 50 now, so it's not quite normal. It's not quite looking at the over 60, but clearly an impressive endpoint, although pointing out that we have a pretty narrow scale in terms of the incidence of events. I'm sorry I didn't have time to make this more legible. I was just looking at this morning and actually had not realized that there is this tiny signal, although not statistically significant, for perhaps small increase in deaths. Very small, probably not significant, but it's one of those things we need to watch as we get more trial data. There is a signal of possible harm for GLP-1 antagonists or agonists with HFrEF, which comes from several different studies looking at both at exenatide and liraglutide and semaglutide, that if we look at the patients who have HFrEF and hospitalizations, the falls on the wrong side for each of the three of those, suggesting that, once again, HFrEF and HFpEF are not the same. So the next step, I think it's hard to know what's going to happen in terms of the guidelines next. As we move on, just about done here, I do want to go back to the fact that it matters what you call it. Now, I want you to picture in your mind, loosely, picture failure. If you had to give a photograph of failure, what would it look like? It might look like this. This is a failure of the bridge, failure of the train, certainly a failure of your vacation. This is failure. Failure has very grim connotations. Asymptomatic heart failure, what's that? Advanced heart failure, like you can fail and you can really fail. And then we have heart failure with normal EF. We all have these patients with HFpEF. Well, if my heart is a normal squeeze, how can it be failing? Replacement is for hearts that are failing. That's when we got used to using this. Basically, if you have kidney failure, go on dialysis. If you have lung failure, you're intubated. But how can you have heart failure with no symptoms? John Cleland said it's time to take the failure out of heart failure. Totally, by coincidence, we both published in the same year on this. Who would be branded with failure? First of all, we have no celebrity champions for heart failure. I mean, we have it for erectile dysfunction, for Parkinson's disease. We don't have it for heart failure. So there's some reason that there's a stigma. Marches for failure, we don't have that. Who wants to employ or insure a patient with failure? And what do you, did you ever talk to the taxi driver? And he says, oh, what meeting are you going to? Heart failure meeting. He goes, oh. The young people dream of going up into failure. We have a real problem, and you have a real problem that we can't get people interested in this field. Do you suppose it's because they don't want to fail? Maybe we should change the name. And how do we recruit mid-level providers instead of waiting until they burn out from something else first? I think we need to come up with a different name and go out into the country and recruit nurse practitioners, because we need a lot more. How about the patients? Are patients lining up to walk into these clinics? How many of your patients say, I don't like that it says heart failure clinic on my appointment because I don't have failure? Interesting, just in terms of history. So what is CHF used to be called congestive heart failure? I mean, that's what the CHF was for. We tried to take the congestion out, and then we just had to quietly change it to chronic heart failure. So we had the same abbreviation. It's very hard to change this, partly because of the pharmaceutical and device industries who all have their indications to give these therapies for heart failure. So what could it stand now for if you didn't want to lose the initials? Well, we think maybe challenged heart function might be something so that you can still keep your CHF name tag. So this has been really a delightful visit, and I'm so thankful to James Resnick and Sherry for sponsoring this so that we can get together. Thank you for your attention.
That's such a wonderful talk. I mean, I feel like you're really defining the field. I've learned so much from you through the years. I'm curious, there's so much data on guideline-directed medical therapy. I know we touched just a little bit on it, but what do you think of sequencing of medications? And the reason why I ask that is there's so many therapies now. The question is, which one do we start first? I know there's some data, for example, from Greg Viral, showing that perhaps we should start all medications at once to avoid treatment inertia, but I think sometimes it's very difficult when patients are a little bit hypotensive or with side effects, there's some kidney injury. The question is, which one would we start? And then my other question is, when there's so many different therapies and the background therapy for each trial is a little bit different, how do we know which one's better than the other, or do we just put one on everything?
It's a great question. It is the question. If you start them all at the same time, I guess you don't have to think about it. Maybe AI can take care of that for you. But you obviously have to make your decisions. I think it's much easier in the outpatient clinic where somebody is stable, they haven't had a recent exacerbation, and then you look at their blood pressure. As you said, you look at their renal function, you look at their kind of tolerability to get into this heavy medical world and decide at that point. Certainly the easiest ones to start are SGLT inhibitors. The MRAs in somebody with normal renal function potassium, pretty easy to start. They don't usually cause problems. Then after that, I look at the heart rate and the blood pressure. If the heart rate is high, then I'm going to prefer a beta blocker. And in general, I think most of us now would try to get people on a little bit of a beta blocker, a little bit of renin-angiotensin, and then work from there. They have to have really robust blood pressure for me to go sort of marching in with Entresto to start with. But if they have a nice blood pressure, I may do that. But each one's individual. And the problem is that most of the patients you see aren't like the patients in the trial. Patients in the trial, a lot of them have never been hospitalized. That's not most of what we see in our clinic. So I don't think I have a good answer for you. That's why we need people trained in this field.
Other challenges I have are people that you see in clinic who are compensated, doing well on no diuretic, and the BMP is 100, and you wonder about putting them on an MRA or SGLT2 inhibitor, and often you put them on it and then they have renal dysfunction, hypotension, orthostasis, and I'm always very reluctant, especially adding the SGLT2 or the MRA, if they are not congested and they are not on a loop diuretic. If they're loop diuretic, absolutely no issue, but I wonder about the benefit when they have a normal BMP and they aren't on a loop.
Yeah, no, I completely share your concern. Some of the data, however, comes from the fact that it was originally used in diabetes, people who were not on diuretics, and it did seem to decrease the first incidence of heart failure. So if I think I can get away with it, I would still like to do it, but I worry much more. I agree with you. People not in a loop. I've had people I've had to take off of SGLT inhibitors because they keep getting hypovolemic. So the neck veins are probably a good thing. If you have someone who's got 4 or 5, which is a lot of people, I'm pretty nervous about starting SGLT inhibitor. But the MRI, I have not had trouble often with the MRAs for that. I don't think that they cause that much diuresis, but we clearly know, I mean, not acutely, it's sort of a slower progression. As we saw in the hemodynamic monitoring, like loop diuretics work very fast, but the MRAs work relatively slower. But it's a really good question, and people have to remember that, oh, we're really happy that, you know, it decreased your diuretic requirement, but what if it's 0 to start with? Good point.
Second question related to that are people who are hyperkalemic on an MRA. I have not been a huge advocate for potassium binders because of cost and other things. And I'm just curious if you have an opinion on that.
I think we're both just too old. You know, I don't like to give 2 drugs. But what's really interesting to me, and the FDA in some sort of unofficial settings has agreed, I don't want to start a potassium binder to let me get an MRA until I have a placebo arm that's getting neither. So if somebody comes in with hyperkalemia, all the trials say, if they've had hyperkalemia, they do better if you put them on a potassium binder. Well, duh. That's sort of like most industry trials, it's designed to win. But my question is, should I just stop the MRA? And no one has answered that for me. So I almost never use it, except in someone who has renal dysfunction that's bad enough that they have hyperkalemia anyway. But I could be wrong, but just someone needs to do the trial.
So I'm an electrophysiologist. That's my disclosure. You hinted
I'm
at this.
partial to those.
I know. You hinted at this, but what's the role of a primary prevention ICD in this population now that we're seeing a decrease in total mortality over time?
I'm surprised an EP guy would expect me to answer that in 1 sentence.
We still got a few minutes.
Yeah, no, it's a really good point. And in fact, there was this article, I think it was Shen, published it in the New England Journal that said, we don't need it anymore. And they had these lovely graphs that showed that sudden death has gone to almost 0. But basically what they looked at was the same slide essentially that I showed you, because mortality has gone down in the recent trials, but those are in class 2. So a lot of the assumptions that are in that article, I think, are not valid. Having said that, it has clearly decreased, and it decreased before ICDs. It decreased with ACE inhibitors and beta blockers. So it's definitely lower. I think that basically we need to do more individualization of it. I think we need to be looking, first of all, once you take the people who have arrhythmogenic cardiomyopathy genes out of there, and we look at the non-ischemic, I think we're going to find that we may not need to give it to all the others. If they have no genetic disease, no LGE, and a negative Holter, I'm not sure we need to be doing it in very many of the non-ischemics. The MI group is quite different. And, you know, I think at this point, if you look at even going way back to SCUD-HEF, the ischemics have more sudden death. So I think it's harder to say. But for the non-ischemics, I think we could start thinking a little more about it. But everyone's going to be very concerned about legal implications. So until there's a guideline that allows us to do this. In Europe, the indications for non-ischemic have gone down from 1 to 2A. That's still a pretty short answer to a complicated question.
Hey, Dr. Stevens, thank you very much for the great talk. I was wondering, with the results of the SELECT trial and other similar trials on the cardiovascular outcomes of GLP drugs and GIP drugs, and also with ongoing discussions about potential expansion of those drugs for insurance coverage, you know, what do you think is the likelihood in the future that GLP and GIP drugs would be drugs that are commonly prescribed by cardiologists, especially given their impacts on heart failure and potentially for cardiac arrhythmias also?
It's a really good question. how should we use it? And, I advocate having our primary care people take a little more care for heart failure. So I'm being kind of hypocritical when I say, but I don't want to do anything with diabetes. So I think we're all going to have to increase our comfort zone a bit, and we will end up prescribing some of them. But you're right, we really don't know what the impact is going to be across a broad group of people. It looks like in HFrEF, it may make things worse in some patients, so we're going to have to be pretty careful about that. There's some signal of increasing AFib. I think we have to be careful not to jump on that bandwagon too quickly, but clearly it offers a tremendous potential. One of the things that I'm particularly excited about from a philosophical standpoint is that noticing how much better people with HFpEF get if you treat their obesity really, I think, turns things around to obesity is causing a lot of the HFpEF. I do want to call out to Dr. Kirkpatrick, in fact, who's been inspirational in a lot of the things he's done on our heart failure pathway in relation to how we should approach decision-making and end-of-life discussions. And I'm hoping that you will get involved in the C2D initiatives, because there are a lot of issues there about how we present things, because unfortunately, particularly at centers like yours and mine, there's this feeling that when you have C2D type heart failure, you either need to go for transplant or VAD or hospice. And in fact, this very large group of patients does not need to go to hospice yet. We can help them to enjoy, further meaningful life. And I think we really need to work at that middle ground.
And in fact, I would say that a lot of your thinking on this issue of trying to change the paradigm of people who have end-stage heart failure or cardiac disease in general, who then get shunted off to hospice as the only option, and rethinking our end-of-life therapies to allow life-prolonging and decongestive therapies. Your sort of advocacy for that, I think, has dramatically changed the way that we have begun to think about things from the ethics and the palliative standpoint.
Well, and I think as I talk about what we call it matters, we probably need to think about using this end of life phrase, because it kind of presupposes the outcome. And, if I die 2 years from now, am I at the end of my life now? And I think we need to realize that the remaining years are very, very important to people there.
Lynn, that was fabulous. Thank you so much. I appreciate it.
Lovely.
Someone's going to make sure. Just in the front. That was good. Putting ICDs in patients, it seems like there is a misconception that patients have to be medical, and I see like it gets lost. I mean, people just get a year or 2 years.
Yeah, on the one hand,